Can everyone see and hear
Yes,
me?
yes, we can, and we can hear you as well very well.
Okay, good. So I'm going to start with a summary of what I'm going to say, which is really this talk is going to be mainly a discussion on liver transplantation for cholangiocarcinoma, two different types, as well as colorectal metastases. I will very briefly mention hepatocellular carcinoma because I think most of us are very familiar with the indications for HCC and the various ways by which we deal with finding an HCC in a patient with cirrhosis. So, and I will also address the issue of transplanting oncologic patients, mainly with living donor liver transplantation. And I will explain in the next few slides why I believe that is the most promising way to address this issue. Um, living donor liver transplantation for these oncologic indications uh, is a complex issue, and it does have its own ethical considerations, and it does require an interplay between the transplantation services, oncology services, as well as allied health professionals. It does appear that primary and secondary liver malignancies continue to grow, and transplant oncology offers promising outcomes in carefully selected patients. So, transplant oncology is an evolving field that combines transplantation with general oncology principles, and it offers an opportunity for cure in very well selected patients, improving survival and quality of life through replacing organs. So, as most of you will probably be familiar, there have been some relatively recent policy changes from this last summer, allowing us to use MELT exception scores for the somewhat unusual oncologic indications other than HCC. So, on the left, you can see that for hilar cholangiocarcinoma, and I'm going to separate the indications for cholangiocarcinoma into hilar and intrahepatic. So for the hilar cholangiocarcinoma, those that meet the requirements for listing, they receive a median MEL score -3 at that center. For the intrahepatic cholangiocarcinoma, or for, I should say, for mixed HCC and intrahepatic cholangiocarcinoma, again, patients received a median MELD -3. Well, whereas for colorectal metastases, the criteria qualifies them for a median MELD -20 with a minimum set at 15. So if the MELD -20 takes them to below 15, they automatically get upgraded to a minimum of 15. Of course, if they have a higher MELD score because of their liver disease, that can give them a higher score. So, what do I think that living donor transplantation is a better option for these patients? Well, living donor transplantation is still a relatively small part of liver transplantation in the United States, uh, with only a relatively small number of centers performing more than 10 living donor transplants per year. The key advantage that these centers have is that they can offer organs to patients with low MEL scores and oncologic conditions that can be disadvantaged by the current allocation system. As you saw earlier in my previous slide, those that have, for example, colorectal metastases may get a max MEL score of 15. And in most centers, that would be unlikely to get them a deceased organ. The donor hepatectomy is usually for adults who will be a right lobe for most adult recipients. The advantages of living donor transplantation in oncology is that you can bypass the MEL system and you don't have to be too concerned about the scoring systems and exception points, and it offers flexibility. It also allows transplantation to be done at the safe oncologic window, where we have seen a disease response to therapy before distant metastases develop. And there's some more of this later on. What the optimal oncologic window is may vary depending on the indication. And for some patients, depending again where they are, a living donor transplant may represent their only chance for transplantation because deceased organs may be unavailable for that male score that they have in the center. There was a publication in June by Byrne, who I think is from the Rochester group, that put transplant oncology in the center of this figure. And it just shows you the interplay of the different specialties associated with the management of these patients. Of course, you have the transplant hepatobiliary surgeons, the hepatologists, and the medical oncologists that we interact with every day. We may need some support from immunology. We know and have our own trusted friends in interventional and diagnostic radiology who often support our treatment of these patients. And of course, the allied health professionals who may be looking after these patients on a day-to-day basis. So, in summary, the selection of patients for oncologic conditions is really a combination of chronology, how long they've had the tumor, and how long they've had the tumor uh, before or after some sort of treatment, and more of this later. The biology of the tumor, we're obviously trying to assess the aggressiveness of the cancer, and the morphology, which may require or may not require a biopsy. So the interest in living donor transplantation for this indication stems initially from the publications of the Toronto group that looked at their transplants for HCC with better results than the deceased group, and you can see their 1, 3, and 5-year survival shown on the left. The benefit was attributed to the increased benefit of living donor transplantation compared with deceased donor transplantation was attributed to the shorter wait times and lower dropout rates. And of course, that can vary depending on your allocation and your availability of deceased organs. This was a study going back to 2012. So there was a single center cohort of 837 transplants from Pittsburgh. Those were not actually specifically oncologic patients, but they did have a higher 3-year survival compared with the deceased donor transplant patients that had a shorter hospitalization with less cold ischemia time. So living donor transplant has become the primary graft source in many countries, especially in Asia, due to socio-cultural and other legal issues. But there have been different philosophies in terms of how you approach this for oncologic indications. Um, there is the conservative approach I'm showing you on the left, where you would consider living donation justified only when you have a recipient with an acceptable recurrence and survival rate. Um, and the focus here is on absolute donor risk avoidance. On the right side, you have some teams considering that living donor transplantation is really an agreement between the donor and the recipient. And if they are both happy to go through the procedure, the procedure does not interfere with the donor pool. So, of course, you have to consider the relative risks with mitigation, but you don't need to be extremely concerned about the recurrence and survival rates in that case. So now I'm going to start presenting some very, very brief information about hepatocellular carcinoma and transplantation so that we have a reference point when we start talking about the cholangiocarcinoma and the colorectal metastases. So obviously HCC is the majority of oncologic reasons for liver transplantation. And there is an ongoing refinement of patient selection criteria. We're still currently selecting patients due to morphology, essentially imaging techniques, but there is probably going to be a gradual shift towards more biology-focused approaches, trying to predict the biology of the tumors. I'm not going to go into that in a huge detail today. So again, these are very, very uh, summarized outcomes. You can see on the left side, I don't think shows very well on the screen. The first two bars really show uh, transplantation for within Milan patients in this is a 3-year survival. Um, and it just shows you that transplantation within Milan has the highest survival and the lowest recurrence rate. The recurrence rate is showing in the light blue. The second two bars represent downstaging um, to Milan, and the third bar represents outside Milan. So as you move towards transplanting more aggressive tumors, you get a decrease in overall survival with an increase in recurrence. In terms of assessing the risk for recurrence after liver transplantation for HCC, we have the retreat score, the risk estimation of tumor recurrence after transplant, that does predict HCC recurrence and can guide post-transplant screening programs. That is a combination of the AFP at the time of transplant, the presence of tumor invasion into small blood vessels. As we know, microvascular invasion is a prognostic marker, and tumor characteristics in terms of the size of the largest tumor and the number of viable tumors at explant. Those who received a score of more than 5 have a significantly increased recurrence risk that require more frequent surveillance. Just very briefly about the emerging role of immunotherapy in HCC. We are increasingly seeing the use of immunotherapy as an adjunct in pre and post-transplantation phases. But one has to be very careful with the timing of this because although it can bridge patients to transplantation while they wait on the list or while we identify a living donor for them, it can potentially reduce post-transplant recurrence, but there are significant risks because there are a number of patients that will be treated with these checkpoint inhibitors who do experience acute rejection, as well as about 50% of them having liver failure and associated mortality. The optimal washout between the last dose of immunotherapy before transplantation is unknown, but it's probably considered to be somewhere in the region of 3 to 6 months. So now I'm going to turn my focus to cholangiocarcinoma, which is the second most common primary liver malignancy. And I'm going to discuss the hilar and intrahepatic disease subtypes separately. Perihilar cholangiocarcinoma is a diagnosis that needs to be confirmed either by a positive biliary cytology or biopsy, or in its absence, by a combination of a malignant appearing stricture, an elevated CA19-9, and suspicious cytology or other molecular techniques. The AASLD recommends transplantation for early stage unresectable perihilar cholangiocarcinoma. And the recommendation is for those with a tumor of less than 3 centimeters. They should not have any intrahepatic or extrahepatic metastases, and the strict diagnostic and staging criteria must be met. As I already showed you earlier, this is recognized by OPTN as an accepted transplantation indication, and there is an allocation of exception points. The transplantation for perihilar cholangiocarcinoma really started at the Mayo Clinic with their Mayo protocol that involves neoadjuvant chemoradiation, including external beam radiation and 5-FU. This is followed by brachytherapy and maintenance capecitabine before transplantation. That's a 5-year overall survival rate in their experience of about 65%, with a recurrence-free survival around 80%. Pre-transplant tumor biopsy and tumor plane violation are contraindicated because of the risk of seeding. This is an important factor, and we do sometimes see patients referred to us who had had a liver biopsy of a small mass that turns out to be a perihilar cholangio that unfortunately rules them out from transplantation. Obviously, lymph node metastases are an absolute contraindication. This is what I already mentioned to you, the Mayo Protocol, neoadjuvant chemoradiation before transplantation for unresectable early stage hilar cholangiocarcinoma. The thing I didn't mention earlier is that this protocol does require a staging laparotomy just before liver transplantation. These are the published survival rates from their original paper from 2005 at 1, 3, and 5 years of 92, 82, and again 82%. This is another schematic showing you the Mayo Protocol that has been adopted by most other US centers. We use a slight modification of this. But once the patient is selected and has been diagnosed with surgically unresectable early hilar cholangiocarcinoma, the neoadjuvant therapy is administered with the external beam radiotherapy and the brachytherapy. And then just before transplantation, there is a staging laparoscopy, which is, of course, one of the reasons why living donor transplantation is important for this group, because you can time all these procedures. There has been a subsequent multi-center study on hilar cholangio and outcomes. All of their patients had CA19-9 levels greater than 100 micromoles per micrograms per mil. They all completed the neoadjuvant therapy before liver transplantation. And as you can see, the recurrence-free survival rates were 78, 65, and 59%, but that is at 10 years. So this supports the effectiveness of neoadjuvant therapy followed by transplantation. So reasonably good outcomes for hilar cholangiocarcinoma. There is an ongoing trial, the TransField trial, that was presented at the Liver Cancer Summit in February this year that compares neoadjuvant radiochemotherapy plus liver transplantation versus liver and bile duct resection. There are 20 patients in each arm. The way it was presented in Paris, the preliminary results suggested no benefit from transplantation, and that is because there was a very significant dropout rate before transplant of more than 50%. Now, the results of those transplanted were very good, but on an intention to treat basis, it appears that transplantation is not superior to resection. Now, the issue is that this study has not yet been presented fully, and of course, we're talking about patients who were able to have bile duct resection, and the ones that we are proposing transplanting are unresectable. I think it remains to be seen what the final results of this will be, depending on what the analysis is. Now, there are some technical challenges in transplanting these patients with hilar cholangiocarcinoma after the Mayo Protocol, especially with living donor. There are some vascular complications. There's a high risk of late arterial and portal vein thrombosis requiring vascular conduits. There's an increased risk of biliary problems. It usually requires a Roux-en-Y reconstruction because of an increased risk of biliary stricturing. And of course, as I already mentioned, there is some portal node sampling before transplant in either the staging laparoscopy or during the donor operation. There's an increased risk of vascular problems, as I already mentioned, when you're operating in irradiated fields. And I already mentioned the issues with biliary strictures. So therefore, before you embark on a liver donor transplant for these patients, careful surgical planning needs to be made. This is specifically looking at the living donor experience for these patients. This was a paper published by Tan et al., the American College of Surgery Journal 2020. 74 living donor liver transplants at the Mayo Clinic with hypercholangio. Once again, they reported high rates of arterial and portal vein reconstructions, commonly used a Roux-en-Y choledochor jejunostomy. There was some late hepatic artery thrombosis and portal vein complications that were expected. And their overall survival at 10 years was 56%. The survival rates for these patients with unresectable hyalocholangiocarcinoma without surgery would be exceedingly low. There was a cancer recurrence rate at about 12% for these patients. So a pretty good living donor experience in obviously a very experienced center. So we're going to move now to discussing intrahepatic cholangiocarcinoma. This type of cancer originates from the intrahepatic biliary epithelium and represents about 10 to 20% of all cholangiocarcinoma tumors. It does appear that the incidence of intrahepatic cholangio has increased over the last decade. Unfortunately, the long-term survival remains poor at 10 to 40% with therapy. And there are some significant challenges in terms of effective treatment strategies. This is another slide showing you the outcomes with a mixed hepatocholangiogram. The overall survival at 5 years is 42 to 78%. But with intrahepatic cholangiocarcinoma and very strict selection criteria, you can also have very good outcomes. The challenges, and I will show you a slide for some of the original studies, that the 5-year overall survival in intrahepatic cholangio showed us a 5-year survival rate of 18 to 25%. So for these patients, surgical resection does remain the primary treatment approach. Unfortunately, it's an aggressive disease. Surgical options are limited because of this, because of tumor location and because of their size. There are often multifocal tumors and extrahepatic extension that further restrict surgical candidacy. Transplantation indications are evolving. Now, the International Consortium for Intrahepatic Cholangiocarcinoma published results with single tumors of less than 2 centimeters that were incidentally found in cirrhotic liver. So this was really transplantation for incidental intrahepatic cholangio. Of course, their survival rates were very acceptable. 1-year survival of 93% and a 5-year survival at 65%. But these were very small tumors found incidentally at the time of explant. There was some recurrence, but that was pretty low at 13.3% at 5 years. So this was viewed as very promising for transplanting very early intrahepatic cholangiocarcinoma patients. Of course, you need to make sure that your pathologist looks at the explant carefully to try and find all these tumors. And at the moment, intrahepatic cholangiocarcinoma remains a relative contraindication to transplantation. This slide just summarizes the results I just showed you. Selection strategies are evolving, but for these very early tiny tumors, the 1-year survival is 93% and the 5-year survival is 65%, with a recurrence rate of 13%. The European Association for the Study of the Liver and the International Liver Cancer Group recommended liver transplantation for these small intrahepatic cholangiocarcinomas in July of 23. They said that centers must be capable of multimodal treatment to control tumor progression with their 5-year survival for patients that are selected carefully in the 63 to 73 range that I already showed you. It was not recommended that transplantation be carried out for locally advanced intrahepatic cholangio outside clinical trials. And the focus for transplantation should be on well-differentiated tumors and strict patient selection. There are a number of ongoing trials. The Toronto trial is well known. The suggestion is that one should consider transplantation for intrahepatic cholangiocarcinoma if the patient has cirrhosis and they're unresectable and they have been responsive and stable to at least 6 months of neoadjuvant chemotherapy. So there is some experience from Dr. Lansford from Methodist in Texas. This is a case series, and the first 6 patients showed a 5-year overall survival of 83%, with a recurrence-free survival at about 50%. There was a 2019 update that included 3 more patients with ongoing good results. So in terms of comparing perihilar and intrahepatic cholangiocarcinoma, the long-term survival post-transplant is better for those who have perihilar cholangiocarcinoma. The recurrence rates are generally lower in those patients, but of course we are comparing all the carefully selected cases. You still have the option of transplanting very small, very early intrahepatic cholangiocarcinoma, and there is an exception score for them. Very early, small intrahepatic cholangiocarcinoma patients do show promising transplant outcomes. So now I'm going to shift to talking about metastatic liver disease that potentially offers curative treatment for some of patients with this condition. And I'm going to really only talk about colorectal metastases. Colorectal cancer is the 3rd most common cancer worldwide. 50% of patients with colorectal cancer develop colorectal liver mets. And out of those patients, 20% may present with metastases at the time of presentation, with 80% of patients with metastatic disease becoming unresectable. So if you look at the 3rd study I showed you here, this is a study from Scandinavia. This shows you that for those with the best medical therapy with liver-limited colorectal metastases, chemotherapy alone gives you very poor results with a 3-year overall survival of 6 to 8%. If you look at the SECA-1 and SECA-2 trials from Norway that I will elaborate further in the next few slides, that looked at liver transplantation in carefully selected patients with unresectable metastases, the 5-year overall survival is in the region of 60 to 83%, with the progression-free survival in the region of 35%. So the foundation of liver transplantation in unresectable colorectal metastases are these SECA trials, the secondary cancer trials that were carried out in Oslo, Norway. SECA-1 was published in 2013, and it showed an overall survival at 1 year of 95%, 3 years of 68%, and at 5 years of 60%. That is represented by the middle red line on the graph on the right. There was a relapse-free survival of 35% at 1 year. But pretty good survival overall at 5 years. The exclusions for this SECA-1 trial are the loss of 10% of body weight and, of course, extrahepatic spread. They identified a number of predictors that they later developed into the Oslo score. Those were a tumor of more than 5.5 centimeters, a CEA of more than 80 micrograms per liter, a time from primary tumor removal to liver transplantation of less than 2 years. So in reality, what happens is that the longer you wait from the time of primary tumor removal to transplantation, the better it is, and that probably reflects the tumor biology. And disease progression at the time of liver transplantation, which means that these patients will be on some maintenance chemotherapy just before transplant, and we want to make sure that they do not progress during that time. Rochester, New York is a place where has pioneered living donor transplantation for colorectal metastases in the US. And they probably have the largest American cohort with the published selection criteria that I've shown you there. That's the so-called Rochester protocol. They have patients that have been confirmed as having unresectable colorectal metastases by the multidisciplinary team. They have to have had resection of the primary tumor for more than 6 months before transplant, and more than 12 months from the time of the diagnosis for colorectal mets. They need to show 6 months, at least 6 months of disease control and a decreasing CEA to less than 80. And of course, they have some molecular exclusions and extended observation from right-sided primaries that appear to have a worse prognosis. They have shown a 1 year survival of 100% and a 3 year overall survival of 91%. And you can see the recurrence-free survival at the bottom of the slide. There's a Transmed randomized clinical trial presented in the Lancet by Adam et al. Last year that compared liver transplantation and chemotherapy versus chemotherapy alone. So the liver transplantation plus chemotherapy shown with the red line, and that you can clearly see that on an intent to treat analysis, there is a 57% overall survival versus a 13% survival with the chemotherapy alone. On a per protocol analysis, you would see that the outcomes are better than this, but still remarkably successful procedure for patients who would otherwise have a very dismal prognosis at 5 years. The SECA-2 trial was published in 2020. They showed, again, an overall survival at 5 years of around 80%, disease-free survival much lower. And they were able to use the Fong clinical risk score, which is a score used in surgical oncology to predict recurrence after resection. This score is a score that I've shown you the components of that on the right. Node positive tumors, disease-free survival, disease-free interval less than 2 months, the number of metastases, the size of the metastases, and the CEA levels. Those who had a high score did significantly worse than those that had a good Fong clinical risk score. And you can see the separation very nicely there. Those with a risk score that was very low did exceedingly well. Unfortunately, those who had a high Fong clinical risk score did badly. So this is another slide reminding you of the Oslo score that I briefly mentioned earlier. This was derived from the second 1 and 2 trials. It does predict survival. It's a score of 0 to 4. 0 to 2 predicts a 67% 5-year post-transplant survival. Unfortunately, a score of 3 to 4 predicts a 17% 5-year survival. And a score of 0 predicted an 89% survival. The Oslo score is is made up of the maximum tumor diameter, more than 5.5, the pre-transplant CA of more than 80, progressive disease on chemotherapy, and time interval from diagnosis to transplant at less than 2 years. You get 1 point for each of these measures. The other important thing to recognize is that in colorectal cancer, most of the recurrences that are seen after transplantation appear to be pulmonary recurrences and may be amenable to resection. So the fact that patients do get recurrences does not preclude long-term survival. So the graphs on the right really do show you that disease-free survival at 96 months, which is the first graph on the left. So the disease-free survival is relatively low, although the overall survival, and I'd like to point out that the time scale on that graph is much longer, so it's almost double the graph on the left. So the overall survival is still relatively acceptable. If you look at 96 months, the overall survival is at 40%, although the disease-free survival is down to 20. Of course, the survival after relapse does get worse, but it does appear that most recurrences are slow growing and may be amenable to further treatment. In terms of selection criteria, we obviously have to confirm that the disease is confined to the liver by using advanced imaging techniques. PET scanning should be used to confirm no extrahepatic spread. The primary colorectal cancer needs to be resected prior to transplantation. They need to have a sustained response or stable response for the 6 to 12 months before the transplant, while they remain on chemotherapy. And progression while on chemotherapy is a strong negative prognostic factor. I already mentioned the CEA level that we would like it to be less than 80. I also mentioned the significance of the liver lesion that we'd like to be less than 5.5, and a number of tumor lesions more than 9 is a poor prognostic factor. The other thing that is also turning out to be important is a low metabolic tumor volume on PET scanning. The use of the Oslo scores and the phone clinical risk score are associated with better survival rates. So the last part of my talk is going to focus on donor safety, which obviously is the highest priority in living donor transplantation. Potential living donors undergo extensive multidisciplinary screening to ensure their safety and appropriate motivation for donation. They get seen by a large team of surgeons, hepatologists, social workers, and psychiatrists. They undergo a very careful evaluation of their medical history, their anatomy with various scans, the presence or absence of hepatic and cardiac disease, as well as infection and genetic conditions. And there are strict UNOS guidelines to ensure safety protocols are adhered to. The A12 study findings, A12 is that adult to adult living donor liver transplant cohort study, showed that there is a learning curve. There is a number of living donor transplants needed to demonstrate safe, efficacious procedure, which is around 15 to 20%. The overall complication rate is around 38%, and the mortality rate is in the rate of 0.2 to 0.4% for the donors in experienced centers. Of course, as I already mentioned at the beginning of my talk, there are some ethical considerations, and you have to carefully balance risk to the donor and recipient benefit. Have to make sure the donor operation happens successfully with minimal morbidity and optimal recovery for the donor. We'd like to have a successful transplant with good survival and acceptable recurrence, and you need to balance the outcomes for both the donor and the recipient. The transplant teams must maintain autonomy to refuse living donor transplant for donor-recipient pairs when the outcomes may not justify the risks involved. I think we are all familiar with uh, patients and their relatives coming to us to uh, ask for consideration for living donor transplant, even though they've been declined for a deceased donor transplant. So I think it's important to maintain your team autonomy. Uh, as you may have gathered from the previous slides, there is still some controversy regarding patient selection criteria for patients with oncologic indications, and you need to have a strong buy-in from your institution and consensus about the acceptable risk to benefit ratios. So in terms of future directions, I think there are living donor transplantation for transplant oncology addresses organ shortage and has innovative approaches. Molecular biomarkers are being developed to assess tumor burden, and we're also developing molecular biomarkers to monitor rejection. Circulating tumor DNA is a promising biomarker for early tumor recurrence as well as rejection. And there is ongoing multi-institutional collaboration to standardize oncologic selection criteria. But at the moment, living donor transplantation and transplantation for these oncologic conditions I mentioned today should be restricted to specialized transplant oncology centers. So the path forward is, in my view, to expand living donor transplantation for oncologic indications. Uh, the living donor transplantation addresses organ shortage disadvantages in the current allocation systems. There's obviously ongoing collaborative future multi-institutional efforts that we all need to support. And I think that's the end of my talk.
George, thank you so much. A wonderful talk. I think we can open this talk for some discussions right now. Let me start with centers where they're doing a lot of living donor liver transplantations. Dr. Dharmesh Kapoor, eminent hepatologist from India. Dr. Kapoor, if you are around, would like to get your insight into it, especially the living donor liver transplantation, uh, your insights from your center experience.
Morning, Sanjay. Wonderful talk. Apologies that I could join in only a little late and miss the first part. Fortunately or unfortunately, that's the only indication for which we offer living donor liver transplants to our patient. I don't have any experience with perihilar or intrahepatic cholangiomas or colorectal metastasis, but I would really love to hear the views of other panelists. But wonderful talk, the latter part very insightful, and obviously, shows the way how we have to proceed in the times to come.
Are they doing for oncologic indications in India yet, like cholangiocarcinoma, colorectal metastasis, living donor liver transplant?
I think the centers and many centers are doing. I don't think we have published results on them yet, but at our center, we are not doing.
Yeah. And George, you want to respond to it? Like, you mentioned about this careful selection for living donor liver transplantations. Our center actually is doing living donor liver transplantation. We recently started. Of course, our major focus is deceased donor here, and then they all get the median MEL score at transplant -20 and the capped at 15. How do we get this patient otherwise with a MEL score of 15, even if they are on the wait list? Even if you use the pump techniques, how do we bypass patients who are higher on the list above 15? How is it ethical? What your take on it?
Well, yeah, I think we've only done living donor transplants for these patients at this point. Now, we've only done them because we had been unable to get them a deceased donor liver, and I think it depends on the part of the country you're in. Our availability of donors used to be of deceased donors used to be very good in the past, and we had the ability to transplant patients with a MELD of 15, but that's no longer the case. Now, is it ethical? I think with careful selection, I think the outcomes from these patients can be very close to the standard indications. There's always going to be a discussion of who deserves a liver more than the others, and that's why I think if we have the opportunity to use living donor grafts, and I think in my experience, uh, patients and their relatives respond to the request for finding a living donor somewhat differently when you have cancer. Everybody appears to be a little bit more sympathetic and realizes the urgency of transplanting somebody with cancer. Whereas, when you have liver failure or liver disease, they see that they're unwell, but they don't really appreciate that there isn't that urgency, I think, that exists when somebody gets diagnosed with cancer.
Yeah, I think that's a pretty appropriate answer. I have a question from Dr. Kalista. Dr. Kalista, why don't you ask this question yourself and introduce yourself as well for our audience? Thank you very much for joining today.
Hi, thank you. Hi, thank you. Yes, I'm Dr. Kemal Kalista from Indonesia. I'm a hepatologist. So my question is, what is your maybe main consideration for choosing living donor liver transplant or maybe deceased donor over the liver dissection in case of metastatic CRC? Thank you.
No, I think I just want to clarify that if it's possible to resect a colorectal metastases, then you should go ahead and resect that metastases. Liver transplantation of any form should be reserved only for patients who have unresectable colorectal mets. So if resection surgery is possible, of course, you need to go ahead and do that. But if it's not possible, we've had patients who've had previous resections and it's no longer possible to do that, then transplantation is an option. Does that answer your question?
Okay, thank you. Thank you, Dr. George.
Yeah, another consideration, George, is there have to be BRAF mutation or left-sided disease with a metastatic disease to the colon, and of course only in the liver metastasis, not anywhere else, before you consider for transplant. Do you think there is a path forward for metastatic disease from right-sided colonic metastasis? And having a transplant done as long as you have a resectable disease from the primary.
Yeah, that's a good question. I think so for the future, but I think it's still early days. I think we need to get more experience with transplanting what we feel right now have better outcomes, patients who have better outcomes. And once we learn how we can stratify patients better, I think we can move towards transplanting right-sided tumors.
Thank you very much. Maybe I can invite Dr. Jalal, Prasoon Jalal from Baylor. Dr. Jalal, please.
Yeah, thanks for very, very, very informative and outstanding talk. So the question about the cholangio, intrahepatic cholangio is definitely evolving, and I'm right now actually with the team of the Methodist. They're having their annual symposium, and they are, as you said, the Methodist and Anderson, the combined intrahepatic cholangio protocol, and for them, any size doesn't matter. As long as the tumor is stable on treatment, they will transplant. So obviously, the general applicability of that one, especially in the US, is problem with the available organs. I don't know how they managed to do it with the orphan organs, but this area is evolving, and we'd like to hear more about from your side. What are you guys doing? As number one. Number two, in the high-level cholangio, majority of the people are very skeptical of the Mayo Protocol. They feel like, as you know, the diagnosis is always, especially in presence of cholangitis and inflammation, a lot of people think those patients were not appropriately selected. So, and I feel that cholangio protocol needs to be modified or changed. It's too strict. It spends a lot of time, and we really lose a significant number of time following the protocol. I think time has come that we move away from Mayo and put our own. What do you think?
Yeah, these are good points. I think if I can answer the second part of your question first, I think in terms of the Mayo Protocol, we've had good success for the people who have made it to transplant with the Mayo Protocol. Our outcomes are pretty good with that. But as you pointed out, the problem is that you do lose a lot of people on the way. Who develop bad disease and more progressive disease. So we're unable to do them. Now, I do get the impression, this is just an impression, I don't have any data to say this, but I do get the impression that we're maybe becoming a little bit better at diagnosing this disease at an earlier stage. We seem to have seen a number of patients more recently who have turned up with somewhat earlier disease. But that's just maybe just the wrong impression I get just from the patients I've seen. Yeah, I don't know whether we can really have any evidence to liberalize the Mayo protocol at this point, because we are getting good results with it, and we're managing to screen out some patients who have probably a bad prognosis. And what is the first part of your question?
About the intrahepatic cholangio, like Methodist, they transplant any patient with any size as long as tumor is stable. It's not 2 centimeters or 3 centimeters. So, what's your experience on that? Are you guys following a specific size? Of course, there has to be no extrahepatic spread. But what's your protocol in your center for transplanting these intrahepatic cholangios?
Yeah, we don't have any experience transplanting these larger intrahepatic cholangios. We stick to the smaller ones. We consider them for trials, actually. We would consider them for a trial. But sometimes you have a mixed cholangio HCC, and then for those we do downstaging in the conventional way, and they may end up with a transplant. But we're not too aggressive with the larger cholangios.
Rasoon, on that note, from your Methodist experience, how they're able to get points? They're larger tumors, not going to get the
they
points.
use exception points. They get by or use orphan organs.
I see.
Yeah, I mean, really, really very aggressive. You have to see the latest data which they published, but literally for them, size is not the matter, no matter what size it is. As long as, if they can resect it, that's the priority, of course. If they cannot resect it, they go for transplant, as long as they're stable on the size with chemo, radiation, or Y90.
Yeah. Well, another question comes, George, if you can answer this. Many of these patients with colorectal metastasis, they also get infusion pumps. And they remain maintained on the infusion pump for a while, and downstaged or controlled tumor that followed by ctDNA and ensuring that they have stabilized disease, and then they get into transplant. Now, of course, disease donor liver transplant is what we consider in majority of these patients, but having an infusion pump, and having that in the tube in place in the artery for a long time, would that be a contraindication or come on the way for a living donor transplant?
Currently, we consider that a contraindication, yes. I think our surgeons feel that it's going to be a huge increased risk for hepatic artery complications.
Yeah, I totally agree. I had some experience on that, and we really hate it because patient comes with invariably stricture and other problems. So I agree with that.
Good point. And maybe I invite Dr. Benedict Maliakel from from Memphis, Tennessee. and also the other attendees. And please, get ready with your questions. And please, I know that you're all over the world. You are all joining today, and then share your experience, and we'll learn from each other here.
Thank
Dr.
you.
Malia.
I'm in Nashville now.
Oh,
That was a great talk. I haven't heard, this comprehensive a talk in this area, which is a very difficult area, as you can tell, and evolving. Uh, the question is, I've had patients with intrahepatic cholangiocarcinoma who've been resected and have done great. So the problem is one, how do you diagnose intrahepatic cholangiocarcinoma for certain without a biopsy? Especially when it is small, it becomes quite challenging, doesn't it? So the question is it resection first and then think about transplant later? How do you pick and choose transplant versus resection in somebody with, say, a single cholangiocarcinoma, um, with or without cirrhosis? I mean, without cirrhosis, especially. Actually, one of my relatives had pretty extensive, more than two lesions, and had resection, and she has done very well for the last 3 years. She has no recurrence at all. The other thing is in terms of Mayo Protocol, because of the extensive selection situation, I think the only way you can say that transplant is better is you have to the 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 intention to treat should be after all the treatment, and then you have to divide the group into two, which I don't think is being done, right? They kind of go into the transplant path, and if there is no evidence of extrahepatic disease, then they will get a transplant. But they go through brachytherapy and chemoradiation, etc., and they're already pre-selected to be much higher survival with or without transplant at that point, I would think. And that's the question. And the last question is, when you're in a small town and you find a patient with something like this, referring to a transplant center becomes quite challenging. Which center, the nearest center versus the best center. And I think it might be better to restrict the transplants for these kind of things to maybe 10 centers in the United States or something, rather than, you know, just open to all, because that kind of dilutes everything, and I don't think the protocol will be followed strictly.
Yeah, I agree with your last point. I think it can be useful to restrict transplant to a few select centers. The only problem is that it's a free market, so everybody wants to get involved, and everybody, a lot of people consider themselves as large centers with the ability to do this, and obviously with financial considerations, they're all trying to sell themselves as major centers that can do this. But there is certainly value to what you said about restricting this to certain high volume centers. Obviously, where you refer from a small place um, depends on a variety of factors. It depends on patient choice. It depends on patient ability to travel and patient resources. It also depends on your own connections and who who may respond to you and see the patient quickly. And obviously, all of these patients, once they get referred, they have a long road ahead of them. It's not just a matter of getting referred and being seen a couple of times. They probably need to stay close. So there are a lot of considerations. But I think in terms of resection for versus transplant for intrahepatic cholangio, I think in our experience, we do still see that most people do go for resection rather than transplant, and that at this point that probably depends on the ability or the surgical resectability, I should say, of these patients. Um, sometimes it may depend on where they were referred and whether they were referred to a hepatobiliary surgeon or transplant first. But we are pretty restrictive in terms of who we transplant. Obviously, I'd like to see the Methodist outcomes and decide whether we can expand more. But yeah, that's what we're doing right now.
In the Mayo Clinic protocol, has anybody looked at viable tumor in the explant as as a criteria for outcomes? Do they look at, I'm sure they look at explants very thoroughly. Do they find, if they find cancer versus no cancer in the explant, no viable cancer, is that a prognostic sign?
Good question. I don't know the answer to that.
Thanks.
So yeah, we can look into that a little later and then and get some more insight into it. We have a question from Dr. Subham Sharma. Dr. Sharma, if you want to ask that question and introduce yourself as well. It sounds like the question is propensity of extrahepatic metastasis is highest in intrahepatic cholangiocarcinoma. What is the solution in cases of extrahepatic metastasis?
Well, I think the answer to that is oncologic treatment with, I presume, chemotherapy. I'm not an expert in that, but I think you need systemic therapy for those patients.
Yeah. Incidentally, we find many times mixed tumors when you're treating these hepatocellular carcinoma patients. And many times we don't biopsy, right? They go for a transplant based on tumor characteristics on MRI or CAT scans. And most of these studies have shown whether they're within criteria, they're great. The outcomes incidentally found mixed. HCCU also showed they have a good outcomes. What if they're outside the Milan criteria and they're within the mixed? What kind of preventative measures would you take? Would you put these patients on any sort of a chemo or wait until the patient has a recurrence to treat? And usually they're very aggressive when they recur.
Oh, you mean post-transplant?
Yeah, post-transplant. Yeah.
Oh, we don't have a strict protocol on that. We've done a variety of things. We have sometimes, if we feel that there's an aggressive mixed type of HCC cholangio, we do send them to oncology, and they have received some systemic therapy. Sometimes when we feel that the tumor was relatively small, single focus that we took out with transplant with no evidence of spread, we haven't sent them. So I don't think we're very consistent with that.
Okay,
and then what do you do?
Well, we had an end up one case that had a pretty aggressive recurrence, and of course we started the patient on cisplatin and Gemjar, but immunotherapy, of course, was a consideration at that time. But we were worried about the severe rejections in post-transplant. We didn't, and the guy had a pretty aggressive disease. Fortunately did not serve. That's why I was asking that question. Would you do something to prevent, especially when you know that the likelihood of having a recurrence is high? Would you do something differently? And we can ask in the audience if anyone has any experience to share as well from around the world. Anyone has experience with dealing with a recurrent disease early after transplant and how they are treating? Audience?
So I think pretty much the use of IO in the early post-transplant state is something that most centers won't do.
Yeah.
For reasons of bad rejections and at times graft necrosis. The mainstay continues to remain oral agents, especially the TKIs.
Mm-hmm.
And I'm talking mostly of HCC now. I'm not talking of mixed lesions. Mixed lesions is a difficult entity in this day and age because the philosophy that we follow is that any patient who has liver observation, and I will not use the word cancer for obvious reasons because the radiologic reporting has come of age. So any patient who's got a liver observation should be followed for a fair length of time, even if they have a living donor option available. So we should almost never rush into transplanting someone just because somebody fulfills a criteria. So supposing, hypothetically speaking, someone has got cirrhosis of the liver and has got a single lesion which looks like LIRADS 5 and it is 3.5 centimeters. And this patient comes with a living donor option and says that I would want an upfront transplant. So again, this just opens a Pandora's box. Would you want to transplant this patient, or would you want to give this patient some form of a liver-directed therapy before you are able to study the biology? So this is a very difficult to answer question.
Excellent points, Dr. Kapoor. Also, may I ask you another question? What's your protocol of surveillance in patients with HCC? We have our own protocol, and every center is a little different. Particularly, I would just share our experience, and then I'll ask, how you guys all doing. For hepatocellular carcinoma, those who are low risk, meaning they're within Milan before transplant and not downstaged, and on explant, if they do not have high risk features, meaning no vascular invasion, microvascular invasion, we consider them as a low risk, and we monitor them every 6 months for the 3 years following the transplant with a CT triple phase or MRI. But if they are high risk, we do for the first 1 year every 3 months. We don't have a specific protocol for a mixed, but I think we are kind of be more aggressive, like I'm doing every 3 months if there is a mixed one and that outside the criteria. What's your, George, you can answer from your center, and maybe Prasoon, Dr. Kapoor, how do you follow these patients? Just for the audience to know, and also to, for the learners to know what's the, there is no recommended protocol. So that's why I'm asking this question.
Yeah, thanks, Sanjay. We do a similar protocol to what you mentioned. We do a CT chest as well.
We do that.
And it's interesting you said you stop at 3 years. Now officially we should stop at 5 years, but
5 years, 5 years.
I can tell you I have a number of patients who I see yearly and continue to want a CT scan just to check that the tumor hasn't come back. So officially we should stop at 5 years, but a number of patients want to continue getting screened. But we have a similar protocol to yours.
Okay, but let me ask you, why do you think somebody will have a recurrence at 5 years? I mean, biologically speaking, like the cancer cell remain dormant and come back at 5 years, or would it be considered as a new disease?
That's good. Well, I mean, sometimes you do get new disease. I mean, we remember the days of hepatitis C recurrence, and we do have some people with recurrent cirrhosis that actually don't need retransplantation. So of course we screen those 6 monthly. That's a different situation. But we have seen some late recurrences. I've seen a late recurrence at 14 years post-transplant. Now, these are rare, and I'm not advocating screening people forever. But that's a good question. I don't know why they have remained dormant and turn up many, many years later, especially since they are already on immunosuppression. So it wouldn't make sense. You'd think that you get a flare and a very quick recurrence, but you do get some of these late recurrences, but the majority will be early on.
Mm-hmm. What others think?
Yeah, so 5 years, and it's aggressive in the first 3 years, and then you make it 6 monthly. So we image cross-sectional imaging every 3 months for the first 2 years, and then every 6 months for the next 3 years, along with the tumor markers.
Okay.
The problem, Sanjay, with the explant evaluation is that it's almost never all or none.
Mm-hmm.
So you might not. So the conventional boxes that you take is whether there is any. So you look at the degree of differentiation, you look at the grade, you look at the perivascular, perineural, you look at the microvascular. But then you can go a few steps further and see, what they are doing with respect to IHC. So I've never seen in the last 2 decades that you would be having a tumor which is completely pristine and knocked out, and some which would be,
Mm-hmm.
absolutely rotten and bad. So
Yeah.
the tumor worksheet just keeps getting expanded over a period of time as our knowledge about the cell cycle pathways improves. So that's why I think it's a good idea not to get carried away and assume that if something is all necrotic and there is no MVI and even the grade is G1, that you could be a little complacent with the surveillance. I don't think that's a good idea.
Yeah. Well, thank you very much. Is there any other questions from the
Dr. George, can I ask you a quick question? Of course, like I mentioned, we don't dabble into transplants for oncologic indications, but I missed the first part of your talk, unfortunately, and I gather from the rest of the talk that you were mainly focusing on living donor liver transplants. So do you think it's a good idea to be transplanting patients with oncologic indications with the left lobe grafts?
That's a good question. I don't have any experience of left lobe grafts myself. I think the Rochester group have used the left lobe, and they're pretty aggressive. They have the biggest experience with living donors. I think the issue with the left lobe is one is size, but I don't think there's any difference in the oncologic risk.
No, I'm talking of risk to the donor, basically. So, the left lobe grafts, these patients won't have much by way of portal hypertension. They
Oh,
won't have
yeah,
much by way of the metabolic demand. The standard arguments that you place for saying that we don't want a small for size graft or a physiology, and that is why we are looking at the voluminous right lobe graft. But we all know that left lobe graft, the surgeons sleep much more comfortably. These are patients who are being transplanted for a completely different reason. It would make sense.
No, yeah, I mean, and I think if it's if the volumes match up and they're feasible, then I think it's reasonable.
All right.
Thank you.
So I think we are at the end of our meeting today. Unless anyone has any specific questions, I can pause for a few seconds. But otherwise, seems like we are at the end of the meeting. See you again in 2 weeks with another fantastic talk by Paolo Angeli, talking about ACLF, actually. So thank you all for joining today. George, thank you so much for a wonderful talk, and look forward to bring you back again in some time later next year. Thank you.
Thank you for having me. Bye.
Bye-bye.
Bye.